I know this thing is on, and I know that you can hear me. Nursing and healthcare needs advocates and activism. So what are you waiting for? Let's do the damn thing. Welcome, Tina, to the show. I mean, it is a pleasure, an honor. Finally having you on the podcast. It's been way too long. We've been doing like back and forth, trying to kind of collaborate and figure it out. You are in Toronto.
I was going to say, now we're in the same place, but
However, you are far, you're downtown, and it's raining. Yeah. It's Friday.
Very rainy.
It's not going to happen. But
I know, I'm looking at the traffic right now. I'm like, ooh, that's already ugly. Yeah.
No, like it would probably take me 2 hours to get to you and then like 4 hours home just because of the traffic.
Mom life, right? You're like, hey, we're in the same place. And you're like, no, still not.
Yeah, it would, you know, if we were meeting on a weekend, it'd probably be a little bit easier, but the logistics for Fridays and just like if there's any games or anything happening at the Rogers Center. Yeah, it's just traffic.
It is, and
it's
right
just
by the
one
Rogers
way
Center.
in and one way out. It's like the Gardner Expressway for me in and out. It's just...
It looks like crap. So good call. Yes. That's okay. We'll do it this way.
But I'm sure I have some thoughts that we might be connecting sometime in the near future.
Yes, ma'am.
But it's such a pleasure to have you on. And of course, I always like to do this just in case someone doesn't know who Mama Nurse Tina is.
I'm sure there's lots of people who don't know.
Give us, could you just give me a little bit about who you are, your background, and what led you into the world of nursing?
Yeah. So I've been a nurse 17 years. So I'm a dinosaur in this industry now. I live in Edmonton. So I've been Canadian this entire time. Surprise. Some people are like, oh my God, you're Canadian. I say, yes, I am Canadian. And I started off in emergency nursing, and it was always a toss up for me between labor and delivery and emergency room nursing. And so I went emergency, and I'm kind of glad I did. I think you get like a ton of beautiful experiences and skills, and your full body assessments are amazing for emergency. And then I moved to labor and delivery in 2012, and that's sort of where I used to always run to the deliveries in emergency. And a lot of, if there's emergency room nurses watching, they're like, oh, it's not, I don't like that. So yeah, I just was like, that's where I want to be. And so I made it there in 2012. I've been there ever since, but I've had the pleasure of educating online for the past about 3 years. And it's just been truly so cup filling and just this awesome full circle moment. And now I get to help people all over the place online as Mama Nurse Tina. So that's been just a real treat and a dream. And it's been lovely.
I've been following your journey, and it's been amazing. I think, all the things that you talk about in terms of bump to latch, all of the work that you're doing, it is so needed. And I think that, maternal health, women's health, it's reproductive health. It's like a huge gap. Like, it's just like, we make up 50%, probably even more of the population, yet a lot of the medications and how we are treated, whether it's even just managing our pain in relation to, our reproductive system is pretty bad.
Because all the studies are done on white men. They just do all the studies on white men, and then they just say, that'll go for women. Yeah, sure. I just recently was completely gaslit by my own doctor, and I was like, cool, this is awesome. So love that for me. So it's like women's health is just, it's a hill that I'll die on, that it needs a ton of work. So I think slowly we're sort of pushing the needle, but I think it's going to take many, many, many more pushes to get the needle where we need it to go. So
yes, and I mean, since we're talking about pushing, we might as well talk about some of the work that you did.
Yes.
And maybe before we talk about some of the work that you did, we could just maybe highlight like a quick report that I saw. It just kind of came across my feed. And there was a report that broke that, this week about Canada's failure to accurately track maternal deaths. This is not really shocking to me.
It's not new either. Yeah.
We kind of were touching on it, and maybe we can jump into our own experiences, our own birth experiences. But again, really looking at what happens in the discharge period. And as someone who does a lot of postpartum education, why do you think we're seeing still so many near misses? And again, we talk about this being preventable, about like the fact that women, it's not just about having more education, it's about access to care, it's about all of these different things. But again, what would you say in relation to things like sepsis and hemorrhage? Once a patient leaves our care, like what is the education that you've been providing women? Because I think that education's a piece, but again, like I think that we need much more solutions. So tell me what your thoughts are.
100%. I believe the keynote speaker, this is ringing about the keynote speaker last year at the Canadian Women's Health Association conference was talking about this thing. She was like, the Black maternal mortality is not being tracked in Canada, which is a catastrophe because it's happening here. Like we know it's happening in the States because we have that data to back it up that Black women are dying 3 times more than their white counterparts. But in Canada, it's just kind of like, and I think there's this weird thought that here in Canada, like the healthcare is amazing and it's free and it's awesome. It's really like we have huge pitfalls in our healthcare system. And one of them are like referrals and wait times and like procedures that need to be done, but maybe they aren't like a super rush. So they kind of get pushed to the side. And so I think we still see those issues in that like 6 week checkup. We still see the issues in these obstetricians' offices that have tons and tons and tons of patients, and they just can't manage those patient caseloads because there's just so many of them, because you have to see somebody. And so you sort of get to see whoever you get assigned to see. And so I think there's still those gaps in care, which is really, really unfortunate. Also, where I work, we have a really, really high C-section rate. And so that's something that is kind of parallel to the United States, is that we have these increasing C-section numbers. And so I think we do have a lot of the same disparities and issues that the States had. It's just that we're like not tracking that. And I don't know if that's just because we have this Canadian rose-colored glasses on and we're like, we have free healthcare. And you're like, no, there's still huge issues in accessing care and in that follow-up. And I think that follow-up has been missing forever. Like literally my 6-week appointment was like, you go in, they're like, how's it going? And you're like, I don't know, like I have this. Oh, that's normal because you just had a baby. But hey, you can have sex because you're 6 weeks postpartum. And you're like, oh, okay.
Like, who's this for again? Like my what?
I certainly was not
top of mind.
I was like, oh, thank God. I'm so happy I can have sex again. You know what I mean? Because it almost is like we view women as like, that's what we're here for. We're just here to make the babies and then to go into perimenopause. And then that's your like life story. And right. I think it's nice that we have women who are pushing for change, because we're like, we're more than that. And we deserve more than that. We deserve better than that. And we deserve better diagnosis. We deserve studies done on women for women. The studies on rats and the studies on white men are not going to be the same for us. We're like our own people. So I think it's nice to see a lot of women, and especially like you're doing a ton of advocacy work, and it's so heartwarming to see us all be like, women deserve better. Like, what are we doing? It's not anxiety and it's not pregnancy. Like those are your two diagnoses you can get. You're either pregnant or you're anxious. And then they just tell you it's going to get worse. And you're like, oh, that's so fun for me after 40.
Yeah, you think that after time, some of this would have changed, right? Like, I mean, if we look back to even to some of the diagnoses women had, right? It was just like, oh, it's hysteria, right?
Yeah, right.
And it's these issues. It's like, well, like, no. We still have so far to go, but we're still using these same terms. Instead of saying they're hysterical, now we just, it's anxiety, or it's in your head, we can't really find what's wrong. So it must be something else, right?
Yeah. I just recently saw the doctor and I said, after I turned 40, things have just gone off the rails. And you're like, am I doing too much?
Understand.
Like, is it, and it's like, and perimenopause makes everything 10 times worse, but we know almost nothing about perimenopause. We just say, that's just what happens when you get older. And you're like, well, yeah, but can we make it better? Like,
right. It's like does it have to be suffering?
And I said to my doctor, I was like, I either have dementia or there's something happening, because I said, I cannot remember anything anymore. Like 3 days ahead of me, I can't remember anything. And he looked at me and I said, I'm thinking maybe it could be ADHD. Like maybe I have had that this entire time. I said, I've been reading, because I did my own research. I said, I've read that perimenopause can amplify symptoms, and often women have masked effectively for so long, by the time they kind of get upwards of 35, 40 years old, they're exhausted from masking all the time. I said, I could literally not keep my eyes open, except at bedtime, I can't fall asleep because my brain won't stop going. And he looked at me and he said,
the same person?
Yeah, right? Yeah, most women are, right? And he said to me, he looked at me and said, but you're really accomplished. As if because I was accomplished and I wasn't like a heap in the corner of the room, I couldn't possibly have something wrong with me. But you've done a lot of things in your life. Okay, super. But something is very wrong and different. So I basically was just like, I'm like, thank you so much. Bye-bye. And then I went and got like an assessment, and it said, I do have ADHD. Good to know that I was not wrong.
How have you watched some of your videos?
With my like with my own intuition, I was not incorrect. That something was off. And so, but that's an example. It's like, if you're not struggling in the trenches, then you're probably fine because you're a woman and you can do it, So women's health it needs some power players to.
It needs a lot of work, and even just backing it up to the fact that when we were talking kind of about in relation to like birth rates and morbidity, mortality, the whole part of like, yeah, we have this robust Canadian healthcare system. It's the fact of the matter is you can't change what you don't measure. If we don't
Yeah.
measure that,
Right.
here are the gaps. Here are, let's look at it not just by, by birth, but maybe let's look at it by race, ethnicity. Well, race again, okay, let's look at it by
Yeah.
ethnicity. But again, putting that quality, that health quality, health equity lens on to the work to say, okay, we have huge issues here, but if we don't measure, we can't
That's right.
really say that there's a problem. And I think that's kind of what we're starting to see in our healthcare system where, we continue to juxtapose ourselves against the US. And yes, their system is not the greatest because of their insurance and various different things. But again, at least they're doing the research. Like we need to
Totally.
do the
And
research and we need to say it's not good enough anymore to be like, well, that's what's happening out there, but things are good here. It's like, no, people are seeing the cracks. We're seeing the cracks as women. We're seeing that we're being
yes.
left behind. And now it's time to do something. And I'm glad again that you and many other women have stepped into these spaces to say, it's not enough and we need much more attention. And really, I love your work because you're empowering women to go about this in a very different way too. To like knowledge is power. I don't think people realize how how important it is that if you have, evidence-based knowledge, you're being equipped, you can then go to your provider and be like, yeah, you know what? I gave you these symptoms, but I don't feel comfortable with what the assessment or the diagnosis you're giving me. I'm going to go elsewhere because I've heard other things. Like, I think that is so powerful for women. So it's so important that in terms of the work that you're doing, because I think that we need people in these spaces. Again, we're seeing groups like the CMA talking about, health misinformation and advocacy and doctors stepping into the space, but we definitely need more nurses to continue to step in this space.
Yeah.
I know people kind of like shy away from the term nurse influencer, and I think that you're way more than just a nurse influencer. But at the end of the day, if you're influencing someone to make a decision about their health that is evidence-based, informed, and can improve healthy outcomes in the community, then yeah, we should all be in this space.
We should all be. We
and
should
it's
all
fine.
be.
If you want to call me a nurse
Yeah.
influencer, I'll take it. Because if I'm influencing, better decision making and I'm using evidence to inform it, why not,
I
right?
agree. Yeah, I agree. And I think that that's important. I always say to people, like, take what you hear on social media and then bring it to your own provider. Because, I mean, the hope is that whoever you're seeing, whether it's for pregnancy or for, anything, perimenopause and mental health concerns, the hope is that the person that you're seeing is an expert in your specific care because everyone's a little bit different that way. And then hopefully they can take that piece and say, yeah, I agree to a point. Here's my thoughts on it. Or I don't really think that that's accurate information. Let's look into that together. I think we need a lot more physicians and care providers who are willing to say, I'm not sure. Let's learn about it together. And I don't think that that's a bad thing. And I would never expect my doctor to know everything about everything, but I would expect them to like take my complaints about my body seriously. And then like if we can come up with a game plan together, it's like that you want to be an active participant in your own care. Like you don't want to just be a bystander being like, okay, cool. And we see this too. Like I saw this in Emerge. You see this in med surge, in geriatrics. Like you'll say to somebody, oh, what medications are you on? And you're like, I don't know, these ones. And they just hold up a bag. And you're like, well, what are you on those for? And they're like, oh, I don't have any health concerns. You're like, what do you on this blood pressure med and this, this antidysrhythmia?
It's like, oh, this is a blood pressure med?
What do you on this blood thinner for? And they're like, oh, I don't know. I think like because they're bystanders because they're just being told this is what you do. And I don't think there's enough people questioning, well, why do I need to do that? Or why do I need to take that medicine? So I would love to see more people be, and I don't want people to go out, and no one wants someone to go out and tell their doctor what to do. Like they've gone to the schooling, they've earned their accolades and they are the expert in their area. But I think what people want is just somebody to be aware that we want to be a participant in our care as opposed to a bystander.
And I think that, even as someone, we are takers of care as well, that like at the end of the day, I want to be the driver, right? As much as someone might be helping me with my care journey or saying, here's what I think might be the issue. I still want to be able to have that control. And I think it's so important, especially, in a society where we have illnesses and disease and things that that sense of losing autonomy, losing the ability to make decisions. Like, I think it's so apparent when you become ill or when, you're faced with, oh goodness, I have this issue with, being pregnant because again, pregnancy is seen as like a normal condition. But again, we're seeing more and more women who are very, very sick when it comes to pregnancy. But having that autonomy, being able to have knowledge and say, I want to be a participant, I want to be the driver, I want to be also a decision maker is super important. I think a lot of women need that language and need to feel empowered to use that language, because I think what happens is, we get into these situations and we just like
Yeah.
forget. It's like, what
You're
what was
you're
I
super
what were the
vulnerable all of
concerns
a
I was
sudden.
gonna say? Or, the doctor's only been in the room for 5 minutes and they're just heading on the way out, and you're just like, "I still have
Yeah,
4 more issues, but they're gone," right?
totally.
So
And that's why I say to people with that 6-week checkup, I'm like, please, like, as you're waiting for it, make a list of your questions because you're going
yes,
to forget them and they'll blow in and blow out. That's what I mean. This 6-week appointment, if you look it up, I do a lot of like looking at guidelines in the States. If you look up with like ACOG or even SOGC in Canada, like that 6-week appointment is supposed to like, it could even replace your yearly physical. Like it's supposed to be very in depth
that's it.
and it's so not. Mine was like, I'm going to do your PAP exam. Let's talk about birth control and it looks great. Go. Like,
Yep.
you're like, what? Like, I have so much things happening. And so, yeah, like it's a big miss. Like it's a missed opportunity as well to like continue to educate women on what they can expect moving forward and what they can expect for family planning for their mental health. Like it's a big missed opportunity.
Yeah, I think about even just going back to that study and talking about postpartum and thinking about even like my own birth experience. And I'd love to hear
Hmm.
what yours were, because one of the questions you had asked me off screen was kind of like,
Hmm.
what was my birth experience as a Black woman? And, like you would think that me being a labor and delivery nurse, because
Right.
that was like essentially what I used to do as well,
Hmm.
that they would listen to me more, that they would be more
Hmm.
in tune and be more understanding. And that was not the case. And I think the
Shoot.
scary piece to that is like, as much as I was a labor and delivery nurse and I had that knowledge, it did not prevent any of the
Yeah.
outcomes that I suffered. So I ended up having twins. I delivered them early, 31 weeks and 3 days. And I delivered them at the GTA. And then I was
Hmm.
discharged about 3 days later. But I was
Mm.
complaining the entire time. I'm like, I'm having trouble breathing. My legs were like tree
Wow.
trunks. Again, I was a labor delivery nurse. I understand swelling in the postpartum phase, or the night sweats and things. My legs were like 4 times the size that they were previously. I
Yeah. You're like,
saw
this is,
some of my charting, because we still had paper charting at the time, and it was like, I received like 4 liters of fluid in the OR. I'm like, some things just seems, and they're like, "You're fine. You're
yeah.
fine. You can go
Yeah.
home." And I'm
And
like,
really, like your body only uses 25% of that fluid. So you're like, okay, that's
"Well," I'm like, "I'm not
okay. There's like
fine."
3 liters of
Well, by the
fluid in my
time
legs.
it's crazy. By the time I got home, I couldn't walk from like my living room
Oh
to
my
like my
God.
kitchen, which was maybe like 15 feet, without feeling like I was drowning. Every time I'd laid back, I just felt like I was drowning in fluid.
Oh my
So I called
God.
my friend who was an OB, and I was like, "Something is wrong. I'm having so much trouble breathing." She's like, "Amie, go to the hospital. You might be having a PE." So I'm like, "Oh no."
Yeah.
So I rushed
Yeah.
to the
Okay. All right.
hospital, and my husband is like the most calm, like collected kind of guy. Like we're like complete opposite. I'm like, "Ah," and he's like, "No, Amie, you got to take it down a little bit."
That's me and my
And
husband too. Possible.
and he wheels me in because I couldn't like walk, so I'm in a
Oh
wheelchair
my
to get
God.
to the triage in the ED. And my husband's like, "She's 3 days postpartum. She had a C-section. She had oh yes, I had preeclampsia. I help. I had
Hmm.
eclampsia, so I ended up having mag
Oh my
self."
God.
And they're just like,
Yeah.
and she's like, "Okay, go to the waiting room." And my husband's like, "Did you
What?
hear
Yeah.
what I said?" And she's
Yeah.
like, "Yeah, just like go to the waiting room." And he's like,
Just
"So we're not gonna go to the
casually go
waiting
to the
room
way. Yeah.
because my wife is going to
Yeah.
die." And she's just
Yeah.
like, "Well, I have to take my break." It was so crazy that like
Yeah. Yeah. Yeah.
sometimes things that come out of nurses' mouth is just like
Yeah.
why would you even think that that
Yeah.
would be the most appropriate thing to say?
Right.
Anyways, he
Right. And
lost
I'm
his
I'm
shit.
willing to bet that that's like there was a huge knowledge gap there because I don't we don't really learn a lot for emergency nursing about pregnancy conditions, like postpartum pregnancy conditions. Like even people, I'll do a video about postpartum preeclampsia, and people be like, "You can't have preeclampsia postpartum," and I was like, "No, no, like it's an actual thing." Like,
Yeah, you
but
can.
again, we don't talk about it enough. So, oh my God, so did you get in? Did you go? Like,
So he lost his shit, and luckily,
yeah,
as he was losing his crap, my OB was coming like down the hall, and she's like, "Just go
wow,
straight up." So then I was admitted to med surg
yeah,
ICU, where I ended up having congestive heart
wow,
failure and pulmonary edema. Luckily, I did not have a PE, but I was prophylaxed, so they gave me like warfarin, heparin, like I had the whole workup. But at
oh
the end
my
of the
God,
day, like I was still critically ill, and this was
yeah,
all
yeah.
due
And did you?
to preeclampsia. Like it was all this postpartum preeclampsia. essentially even though you've given birth, the body's still
Oh my
like,
God. Yeah.
no, the body still has like
Yeah.
lots of issues.
Your
So
body's like, hold my beer.
yeah, like
I have one
we're
more
not
stick up
done
my
yet.
sleeve.
And
Watch
but there are a lot of women who, and we've seen it through various different reports and stories
Mhm.
that have died in the postpartum period, anywhere between like 72 hours up to even sometimes I've seen a week
Mhm.
in relation to these similar complications. And there is not enough education. It is crazy.
Mhm.
Like I was told you need to continue checking your blood pressure. Like subsequently down the lines, like you need to
Yeah.
continue checking your blood pressure. You might have to stay on blood pressure medication because after I had my twins, my hypertension didn't go away. It stayed with me.
Mm.
My
Mhm.
my pregnancy with my daughter was uneventful, but then I had with my last daughter, I ended up
Yeah.
having severe preeclampsia again. So I am
My God.
still on medication for
Right?
hypertension. And like
Right?
again, yeah, sorry, go ahead.
And that's not, like, mentioned enough in your postpartum discharge. Because again, here's another failure in our system is that we have these overwhelmed units and these nurses who are expected to take care of these huge numbers of patients who can have quite severe illnesses and issues, and that's not so then you go all the way till 6 weeks, and, like, let's say at 6 weeks, you're like, "Hey, like, I don't know, like, I just every day I have this headache, and I don't know, I don't feel well, I'm swollen," and at 6 weeks, they're like, "Holy shit," you have your blood pressure is 150 on 110. And has it been that way for 6 weeks? Because we just get told, "See your provider at 6 weeks." We don't get told, like, "If you have these concerns, check in sooner." This is like a message that if you could blast this out, you can see your provider sooner than 6 weeks. You don't have to wait till
100%.
6 weeks. Like, that's this number, this magical 6-week number is but I wanna ask you because I asked somebody else, Dr. Bio, I don't know if you know her, she has a
Yes, I
very
do.
similar story. Okay, so I asked her the same thing. I said, "In that moment where you were like, something is not right, and you were swollen and you couldn't breathe and you felt like you were did you think in your head, like, I am right now becoming a statistic? Like, I right
100%.
now am part of the statistic."
100%.
Crazy,
So
crazy.
that was the experience with my first pregnancy, and
Jesus.
I couldn't believe that, what was happening to me. Because again, it's
To
one
know.
thing to be a labor and delivery nurse and being on the other, end of the bed, and then
Mhm.
being the person sitting in the bed, and then reading
Mm.
all of the various different things that have happened to Black women, knowing that,
Mhm.
this could be me, this is me.
Is me.
And I took the reins with my last pregnancy, which I
Ugh.
don't, and again, this is where, like, as someone who understands the environment, I know a lot of women don't have this knowledge. So
Mhm.
as soon as I was diagnosed with preeclampsia, I went straight into like looking at the various different types of medications that I could be taking. So I was already on certain medications. But again, when I was getting closer to the fact that like I knew that I was going to deliver. I was going to have a preterm birth.
Mhm.
When I was admitted to this tertiary care center, they were like, okay, we're going to try you down this path. And I was like, you know what? I do not want to go down the same path I went with my twins because by the time I was so sick, my postpartum period was like
Ugh.
problematic. And
Yeah.
I was on eight different
Oh my god.
hypertensive medications maxed out, okay?
Mhm.
And of course, the medical surgical OB was like, "We can keep going with medications." And I was like, "No, we're not. We are
What?
not gonna do this." I'm like, "I wanna deliver now.
Yeah.
I am done." And they're
Yeah.
like, "Are you sure, we can get more time?" I'm like, "I know that the longer she's in, the better it is for her, but it
Mm.
might not be better for me."
That's right.
So I was like, I'm like, "We need to deliver. Bring me the
Yeah.
paperwork. I'm going to
Yeah.
sign it today." And they
Yeah.
were very receptive. But I
Okay.
know that's not a lot of women's ability to
Yeah.
make that decision, right? Like I know I was in a very unique place and my postpartum was completely different. Like
Mhm.
night and day, like able to get up, move around, walk. They
Right.
also did keep me for 5 days, which was a part
Mhm.
of my own planning because I said, they discharged me too early with
Yeah.
preeclampsia and I was like, I want to stay for 5 days. And I know that's not the case everywhere, but I do know that there are certain programs where I think it's called like the 5 day sleep and night. So for example, if you had history of postpartum depression, there's these
Mhm.
things that hospitals can put into place so you can stay longer. And again, if you've had preeclampsia initially, your postpartum stay should not be 48 hours. It should be longer.
Mhm.
And
Oh,
I know
yeah.
a lot of women don't know to ask for these things, but again, why do they have to ask? Like it should just be the standard of care, right?
I agree. And then that goes to being like an individualized care plan, right? Like we were like, "Oh, you had a vaginal birth, you have 24 hours. You had a C-section, you're 2 to 3 days." It's like, well, how about we look at like why they had a C-section or how was the vaginal birth? I mean, I've delivered people with, fourth degree tears and hemorrhage, and they have balloons inside of them to keep them from bleeding out. Like, I think maybe that could be a longer hospital stay, like so. But also that's interesting because as Canadians, like, I always think about this. This is like in the States, if you knew that you needed that longer stay, but you had to decide between like needing the stay but being able to afford it, or does your insurance cover it? Like that breaks my heart that
Yeah,
you have
it's
to pick
wild.
between like receiving the care you deserve and need for your own condition, or being like bankrupt or having a hospital bill hanging over your head that you know you can't afford. That's, I guess, a plus of the Canadian system is that you're like, I need to stay in longer. And they're like, okay. And you don't walk out with a big bill. So I'm like, nah, like we have issues, but sometimes it works out in our favor, I think.
100%. Like I couldn't imagine some of the women who end up delivering and then their baby now has to go to the NICU. That's like an additional
Uh,
charge. And if if
uh,
they're like some of the stories I read about women who deliver in the States are wild to me. And just
whoa.
it's, as much as we have issues with our system, at the end of the day, I would still say that for the most part, people are getting pretty good quality care, and
Hmm.
that the standard, although it
Yeah,
needs some work, is
it
still,
does.
I'd say, equal, not
Hmm.
fully equitable, not
Hmm.
equitable, but fully, but equal in terms of
Hmm.
how it's going to be delivered. I want to
Hmm.
talk about a little bit about, where you are. So you live in Edmonton, and I know you have a higher Indigenous population. We kind of
Hmm.
touched on it. So we definitely talked about Black women, but I'd like to hear a little bit more about your experiences with Indigenous women and maybe some of their experiences, because I do know
Hmm.
that racism is a huge issue,
Hmm.
not just in Alberta, but
Hmm.
really across Canada. And one of the things that, like, today actually is Indigenous Nurses Day, and
Shit.
it's so important that we celebrate and we
Oh
talk
my
about the
gosh.
great
Happy
things that,
Indigenous Nurses Day.
right? And that we talk about, the pioneers that came before us in terms of the Indigenous health. And, speaking of Charlotte Mutton, who was the first Indigenous nurse in Canada, but also just the fact that, how far have we really gone?
Mm. Mm.
Again, when it comes to whether it's sterilization, whether it's, discrimination, what are some
Residential
of the
homes.
things that you
Yeah.
see, and how can we better work towards this truth and reconciliation in relation to, birth for Indigenous folks? And again, I
Hmm.
think it'd be great if we had an Indigenous voice, and I think I'll make sure that we do that. We bring
We
that in
should. We should
another
get one.
time, but just kind of like, what have you seen?
Unfortunately, I think they're definitely painted stereotypically, especially in an emergency department. We have a few emergency departments that are kind of right in the dead center of the city, and they see a large Indigenous population. And I think there is definitely that stereotype that we see them as people who are not worthy, people who have less money, have less status. On my birthing unit specifically, that's nice in that we do actually have like one room that's set aside for Indigenous people if they want to do saging or any of those types of their cultural traditional sort of ceremonies with their births, which is lovely. But I think a lot of people don't come in necessarily wanting that, and so they just get lumped in with everybody else. And it's sad that we have to be like, okay, we're going to treat you like this beautiful Indigenous human being having a baby if you want to do all these things, but otherwise if you come in with the same complaints that we would expect you to have, we're going to treat you this way. And so we have a long way to go. And I would love to see more research on Indigenous people and how their births are going. Like, are they comparing to Black and Brown women in Canada like Black women are in the States? Like, it would be really interesting because I don't think that they're getting the care that they deserve or that they are worthy of having. I think we don't take them as seriously as their white counterparts in terms of things like pain and need for things. So I think it's really unfortunate. I see it a lot in the emergency department when I used to work there, and it's really unfortunate because it's like they're human beings and they feel pain, and if they say they have pain, they have pain. This is something I've never really understood. I see these like videos of people who say things like, their pain, they say it's this, but I'm going to give them this medication instead, like making fun of people and how they experience pain. And I'm like, I don't understand it because I'm like, are you paying for that pain med out of your pocket? Like, I don't understand what the point of withholding meds or being disgruntled about giving a med is. Like, you're there for 8 hours regardless. Like, just take care of a person like a person, give them what they need, and then move on with your day. I don't understand it.
Yeah, the
I
whole
don't.
policing of
I
medications is,
like
it's wild
they
to me,
say they
right?
had pain. I was like, but if they say they had pain, that what? Like, who are you to judge? Like, just give them the med. Like, that's part of your job. Like, you're there work your shift, like give them the
Yeah.
meds. It's not your personal stash that you're cutting out of. Like, I don't understand. I don't.
Yeah, no, I think if we look at like the root cause, again, it's
Mm-hmm,
built in those
mm-hmm,
stereotypes. It's the whole idea behind people being, oh, this group might be more susceptible to be addicted
mm-hmm.
or
Yep,
addiction. It's all
yep.
BS, right? And again, I think this is where education and as well, not even just education, again, I'd say is
Mm-hmm,
always the lowest rung. Forcing functions is highest. But again, if we have some form of a combination of those things, and then at the end of the day, really, it's indigenous. We should be knowing about, indigenous ways of knowing,
mm-hmm.
traditional forms of healing, and they should be the ones that are kind of,
That are
leading
leading
what
it.
the
Yeah.
patient care should look like. I know that there are some centers here in Ontario that are like really looking at having indigenous people as like indigenous doulas, having,
Mm-hmm,
healthcare pathways, or someone who's actually like a patient navigator that's indigenous. And I think
mm-hmm,
those roles should always be there. Like, it's just like, why
mm-hmm,
are we inventing these things? These
mm-hmm.
things should be as Canadian as the maple syrup that we put on our, on our toast, or whatever the case may be, right? Like, these things should be inherent. And it's really surprising to me that, like, there's these kind of like, oh, make like, here, we're gonna just do this. Here's this special room. But it's like,
Mm-hmm.
really, we should be,
It
it's
needs to
not
be
even
deeper than that.
catering towards, it's like, this is how it should be. And again, I just think to myself that there's so many gaps, even just this week,
Mm-hmm,
I've been learning so much from Indigenous nurses, just about even, about today, and just learning that there are certain ways and things that they do. And I think it's our role as nurses too, to be like, okay, how can we deliver care that's
mm-hmm,
more not just culturally appropriate, but that we are understanding, where people are coming from, and learning their traditional ways of knowledge, so we can actually take care of these patients, right? I think at the
mm-hmm,
end of the day, the onus has to come back on us. And again, I think that I would probably say that, maybe Indigenous nursing voices aren't often heard within our spaces too, right? And I think that's a problem, where we need to make sure we amplify the voices of Indigenous nurses. So again, like, I just think there's so much work that needs to
There's
be
so
done.
it is. It's like we're just rubbing the surface. Like there's so much. And then you talked about doulas. This is interesting too. So we know that doulas can go a long, long way in people's care, like that continuous labor support. But I always say, like, if you can try to find a doula that's culturally aligned with you, you're going to see even more benefits. This
Right.
goes for Black, Brown, Indigenous, whatever it may be. Like if you hire a doula that you don't align with, like that just doesn't get it, it's not going to do you the justice that it could do you if you were culturally aligned. So I think that that's a really important point, especially for our Indigenous populations. And like I'll be in a birth with an Indigenous mom, and what I love the most is like the women that come to support them, like their moms and their aunts and their sisters. It's like it's really, really cool. It's like a lot of times they'll have this sisterhood of like you're having a baby, and sometimes there isn't a dude in the room, and it's just like a bunch of us girls, and we're doing the damn thing. So that's something that I've really come to appreciate about it, is that support of the women in their life for them. But if you have a doula that, like I said, that you just jive with, and that cultural alignment is beautiful.
Yeah, no, I think that's exactly, I think, what women need to hear. And I know that there are
Hmm.
some places in the States where they're like banning doulas or banning
Oh,
midwives. I'm like, what is happening? And again, we could definitely get into the slippery slope of talking about what's going on out there in relation to women's care. And then definitely we need to have that conversation. But again, it's just
hmm.
like, at the end of the day, if we think about, how women delivered and gave birth, we gave birth in with
Hmm.
other women around
Yes,
us,
it was like
supporting
it's a
us. It was
village
it
of
was a
supportive women.
community event in some
Hmm.
cases, right? Well,
Hmm.
and again, there
Hmm.
are instances where at the labor and we do the hard work of kicking people out of the room because it's the patient's wishes. But again, in some communities and some cultures, that it is an event that
Hmm.
other women are relied on. So again, I think it's so
Yeah,
important that we have,
and I love
people that
that.
are educated in that space that can help support other women that are going through, I would say, probably one of the most pivotal times in a woman's life. Like, I can't really think of another. There might be like one or two, maybe,
Mhm.
maybe.
That's a canon
I think
event, in my opinion.
it's the biggest.
Canon event. Like you cannot. That's it. Like that's the
Yeah, you
moment,
can't really
right?
top that. Yeah.
And sometimes for our Indigenous populations too, like that is a hugely pivotal moment for that. Maybe she's younger, maybe it's her first baby, and her mom and her aunt are there to help her too. Like that's her becoming like this new version of herself, like becoming a mom with your mom and your mom's mom. Like for a lot of that, that's it. Like that's the moment where like you become this full circle woman. You know what I mean? And so that can be really special if we can just sort of I don't know, figure it out in our heads. Like for some reason, there's just these like roadblocks to us being like, they're a human. Culture aside, that's a human having a human. You know what I mean? Like this is an amazing moment. And how we treat them in that moment is going to greatly affect their postpartum recovery. It's going to affect if they want to have more children. It's going to affect how their family comes together. Like it is a canon event. Like you can't, that's it. That's the moment.
Yeah, I agree with you. Let's take it to a little bit more of a positive. Not, I shouldn't say it's not. We're not talking about positive things, but
Yeah.
let's take it to a little bit of a lighter conversation.
Yeah.
What are some of the things that you're seeing that makes you excited about women's health care at this moment in time?
You know, I think it's that women are coming in with these incredible birth plans and these incredible ideals for what they want to do. And like, I don't care. I always say, like, you can have a baby without a birth plan. The baby's still going to come out one way or another. But like,
Yeah,
when someone comes in with a birth plan, it makes me excited because it tells me that they have like done research and looked into things that they want for their birth and things that are important for them, you know, and then it tells me like, that they have an idea of how they want this to go in their head. And so it becomes like almost a challenge for me to see how close I can get it to like those ideals for them, knowing that how they feel about that birth is going to translate into how they are as a mom and how they are postpartum. So I think that that's really exciting. I also think we're seeing this circle movement. These are like such silly things, but like where more people are not finding out the gender before they have their baby, and then their partner can like announce the gender. That always like makes me get all teary eyed. And I think just people being more involved in their care overall is really cool to see. And this younger generation of obstetricians and midwives and nurse midwives are coming up, and they're like meeting that challenge a lot of times because they're also learning as they go. And so it's cool to see sort of the pendulum swing.
yeah, I think I'm seeing that too. I would agree with
Hmm.
that more providers are willing to kind of meet their
Hmm.
patients. I shouldn't say halfway, but you know what I mean.
Hmm.
That
Yeah.
the idea behind kind of the shared collaborative,
Hmm.
relationship, I do see that it is transforming. I did have some OBs that I used to work with that were not like that,
Oh, let's
but
be
I do
real.
see that it is shifting.
Yeah, somebody has like 5 years left of their practice. That's it. It's an old dog new tricks. It's not happening. I think we have these, and I think too, I would imagine, and I've been trying to get into universities to talk about like birth trauma. I have a huge passion for birth trauma and knowing that 1 in 3 people are reporting birth trauma, and then knowing that we can directly change that number. So I have this huge passion about talking about it, but I had a really hard time with a roadblock getting into universities and colleges to try to talk to the people who are going to be needing to put that into practice. It's been tricky, which is frustrating, but I think that that should be a pivotal piece of teaching information for anybody that's on that track for women's health, maternity, obstetrician, gynecologist, midwives, nurse midwives. Like I think that talking in depth about it is really important because we've heard this a lot before, but it's like it doesn't take a huge catastrophic event to cause birth trauma. Like most birth trauma, I would say from what I've seen and heard, comes from people who just feel like they didn't have any role at all in their birth, and you could have a birth plan that went exactly as you wanted it to go, and you can still walk out with birth trauma because they feel like that they still weren't an active participant, even though delayed cord clamping, even though no episiotomy, even though X, Y, and Z, they still are like, that was traumatic because I wasn't part of that story and that communication. Or you can have somebody who had the most catastrophic birth, but because they were spoken to as a person and they were allowed to partake in that experience and feel like they were driving part of it, they feel like they had a great birth, even though they end up in a general anesthetic C-section. Because leading into that, it wasn't traumatic. And coming out of that, it wasn't traumatic because they were involved in the care and the conversation. So I think we need to have that as like as a tower in the education of these people who are coming into the practice. And that's, I think, how we're going to see more change in how we're talking to our patients.
Yeah, I'm glad that you brought that up because that is something that I've heard a lot about. And again, I guess this could kind of dovetail into this whole like 6 week appointment where it doesn't
Mhm.
have to be 6 weeks. But again, that just that mental health aspect, right? Like I saw studies where they were talking about like women talking about, how many times they were asked about their mental health in the postpartum period. And it was frighteningly low, where
Yes.
a lot of women are still struggling in the postpartum fear in relation to and just having to understand the difference between when it turns from, those baby
Mhm.
blues to like postpartum depression and then
Mhm.
obviously further on postpartum psychosis. And again,
Mhm.
that is definitely not something we
Just
talk
so
nearly
scary.
enough about. I think there's a lot
Mhm.
of women who experience like
Mhm.
postpartum depression, and again, so much stigma around this because again, you see those sensationalized situations, and
Mhm.
those are few and far between. And I think at
Mhm.
the end of the day, it's like people don't understand how truly sick someone is to hurt themselves or to harm someone else, and that we do not do ourselves any service by not talking about mental health and supporting women after birth, because like I said, it can be, one of those pivotal moments. And with a birth trauma, that could be something that,
Yeah.
leaves someone in a place of, dysregulation, distress, and treatment is so important. And it's not just talk therapy. You might need
Yeah.
medications and various
Yeah.
different things to help. So
I
I'm
did.
glad that you brought up
I
the birth
do.
trauma. Yes,
Yeah.
I did
With
too.
with my fourth, which
And
is
I think
wild
it's
because like
fine. It's
the
normal.
3
It's
before that,
normal.
not at all, and the 4th one just, like, blew my world wide open. But that 6-week appointment, it drives me crazy because by 6 weeks, a lot of things are too late. By
Right.
6 weeks, if you're having troubles with breastfeeding, it's, like, pretty much game over. Like, that needs to happen within the first week or 2. Like, if you go longer than 2 weeks struggling, chances are you're done breastfeeding. Same thing with mental health. Like, that postpartum switch off from baby blues to postpartum, it happens so much sooner than 6 weeks in most cases. And by 6 weeks, it's like you're so in the depths of your own hell that you have not enjoyed your baby, which probably is going to interfere with how you're bonding with your baby, which is probably going to interfere with your breastfeeding experience. Like it's 6 weeks is just too late for a lot of people. And so I think a lot of times we don't want to talk about like what happens if you feel like you want to harm yourself? What happens if you feel like you want to harm your baby? Like nobody when they're being discharged in the hospital with their sweet bundle wants to hear the nurse talking about, this is what I want you to do if you think you're going to, hurt your baby. Like what do you mean hurt my like I would never hurt my baby. But if by even mentioning that in the slightest, that plants a seed that if something is happening down the road, they're like, wait, we talked about this very briefly. Like, this is maybe not as abnormal as I think it might be because they took the time to talk about it. Right. So that 6 week is like, it's too late. It's too late.
You're right. No, I agree. And I think,
Too late for postpartum preeclampsia. It's too late.
Yeah, no, you're 100% right, Tina, and I think that those conversations need to be had way early on. And I remember when I had postpartum depression, and it was bad. And I was very fortunate again because I was a labor and delivery nurse. I came from a culture where we didn't actually speak about these things, but because I was educated and I had people around me that would have these conversations, I knew that I was like, yeah, my thinking ain't normal. So I think I need a little bit more help here. And there's a lot of women who experience that, who's fearful to just even say like, I don't want to pick up my baby. I or
which is like
I just feel so sad. I just feel like crying all the time and it hasn't gone away and it's been weeks. You need help. And I think it's okay to ask for help and to get the help that we need. Again, I think the world of women. This is why I did my master's degree in women's health, because I really do believe that we're the shit.
Oh yeah, a man could never. I always say that a man
No,
could never. Like, are you kidding me? A man could never.
Definitely not. But
Yeah.
one last thing, Tina. You're a comedian.
Yeah. I'm
Tell
trying.
me how you
trying.
landed into how does birth and comedy and nursing come together? Tell me a little bit about that.
I always tell people, they're like, why did you start doing that? Like, that's to me, like people are like, I'm scared of public speaking. They're like, stand-up comedy would be 100 times worse. And it is
Right?
it's scary. But like my whole life, people have been like, you're so funny. And I was like, okay, so I gave it a try. And the first couple times it was so bad. It was awful. It was almost a year ago today. Like this is like my anniversary. It was so bad. And I phoned a friend and I was like, I don't know why am I doing this to myself? And they're like, Tina, if I picked up a guitar twice, I would not expect myself to play a whole thing. They're like, it's hard. If you enjoy it, keep doing it. But I think being funny in real life is so different from being funny as a stand-up comic. Because like when you're funny in real life, you have the whole conversation to like build the joke to the punchline, and it's already there for you. You like when you're on stage, people just look at you and they're like, "Okay, make me laugh," and you're like, "Shit, okay." So, but the more I did it and the more I relaxed about it, it became really fun. And it's almost like challenging. I think the challenge comes from like the really small rooms where there's like 5 people and like 3 of them are comedians. So you have like 2 people you're trying to like make laugh. I think that's where like the magic comes from. So I've had a really, really good time with it. And I feel like, like as women, we like put everything that we want to do on hold when we have our kids. Like I have 4 kids, you have 4 kids. Like for 10 plus years, it was on hold because I was either growing a baby, breastfeeding a baby, raising a toddler. Like you have a toddler in the preschool, you have like an hour to yourself. Like you don't even come home half the time because like you're like, what's the point of this? So now my kids are a little bit older. Now this is the first year they've all been in school for eight like hours a whole day. And so it's given me this like ability to do the things like to really focus on the long form YouTube, which I love so much because I like to talk. I don't know if you can tell that about me. I like to talk, and it's hard to get it all in a minute, right? So YouTube has been just so enjoyable for me. And then this comedy thing, like having the time to actually put into it, this has been the most fulfilling year for me with connecting with people, with public speaking about birth trauma, public speaking about utilizing social media to spread information, doing comedy that like brings me joy and makes people laugh. Like it fills me up to see people having a good time. It's just been amazing. And the people that I've met and that I hope to meet in person soon, it's been just lovely. So I love it. And you can, on my socials, I usually have all the places that I'm doing. I'm doing my first headlining event next month, which is very exciting.
Where is that going to be?
It's a home in Edmonton. So if y'all are
All
in
right, all
Edmonton,
right.
and I'm
Oh,
trying to, any of the women's health people, I'm trying to get a little something going on for A1 conference in June. So hopefully I can get something going there
well, that'd be
for all
so
the
cool.
women's health nurses that'll be out that way.
Oh my goodness, that'd be so cool. I
Mm-hmm.
think that, you put out a really good point there. I think sometimes as women we do wait to do these things that we really enjoy. And again, like I just my dad just passed in March, and I think that at the end of the day, we always feel like we have more time.
Yeah,
And
true.
pretty much with his passing, I was kind of like, you know what?
Mm-hmm.
Why wait? Like, if there's something I really want to do, why wait? Like,
Mm-hmm.
tell the people that you love them whenever, give those hugs, do those fun things, roll around the snow extra with your kids.
I
Why
love that. We don't
wait?
need a
Right?
special occasion to say I love
We
you.
don't.
Yeah.
I used to have these special plates that my mom gave me. I'm like, break out the
What?
plates. We're eating
Right?
pizza on them.
Yeah.
Like,
Right? Like
why,
wear the
why
dress.
wait?
Like
Right. And I think
put on the
I love
makeup.
that you're doing something that brings you joy, that you feel passionate about. And it doesn't
Mm-hmm.
matter whether, you're learning and you're growing. That's all a part of the process. And I think that's
Mm-hmm.
what people need to take away from trying something new, that,
Mm-hmm.
at least you're trying. Cause I think there's many people who wouldn't even dare, right? I put my hand up to
Fair.
say that I might not try stand-up comedy. But
Yeah.
again,
It's
at
a
the
lot.
end of the day, I'm so proud of you that you're
Thank you.
taking life by the reins and saying that I'm going to do what I want to do, because I hope that more women can follow that
Mm-hmm.
example and kind of take away some of the things that we talked about today.
I think
So thank
this was my year. This was my year. I said, this is the year I'm just going to ask for everything that I want. And I literally have just been like doing the most ridiculous asks. I saw a video actually on this girl that said what did she say? 1,000 chances to get a yes. And so she's just been asking for these absolutely ridiculous things, like messaging famous people and big CEO people. And she's like, surprisingly, a lot of them are just saying yes.
Yeah,
And so I
you'd be
said, to hell with this.
surprised.
I'm just going to ask for what I want. And so far, it's working out very well. So just ask for it. Just ask for it. Worst, I tell my kids, worst thing that'll happen, they'll say no, and nothing changes.
And nothing
Best case, they'll
changes.
say yes, and you don't know what you've just cracked wide open. So
You're
just
100%
ask for
right.
the
That's
thing.
that's my husband's mantra. He's a social worker. He's like, never be afraid of a yes.
Yes,
So just
right?
just go out there and do it. So I mean,
Such a
there might
pleasure.
there might be more to come. Who knows? I've always said, I have never done a TikTok dance. I'm going to do it one of these
My
days.
gosh.
I'm
I used
going
to
to
do
do it.
them, and now
I
I
don't
look
know
back on them and I
when,
was like,
but it's gonna happen.
oh, I'm waiting for it. I'm ready.
It,
Tag me in
before
it.
we go, is there any right? Before we go, is there anything that we might have missed today that you
Oh
want to
my
touch
gosh,
on?
I think we could talk about this for years and years and years. I think the big important take home is like always like do that research ahead of time. Information is power. It's going to be your best weapon. Have a supportive support system that's not afraid to speak up on your behalf, because even the strongest people, like this is probably me as well, you're the strongest human with the smartest brain, but like when you are in that vulnerable position, sometimes your voice gets quiet. I always say I'm really loud, and then my blood pressure was like 68 on 40, and then I was not so loud, and I needed somebody else to help me. Yeah, knowledge is power. Have your village with you that's ready to go to bat for you, and really just take everything to your provider as a conversation starter. And if your provider is not willing to have a conversation with you, then they might not be your best match because they need to be a part of the team as much as you are.
Yeah, no, I love that. Where can people find you, Tina?
Goodness, I am just everywhere. Any social media, you can find me. I am either Mama Nurse Tina with underscores, or I'm just simply Mama Nurse Tina on YouTube and Facebook. And then bumptolatch.com is my site. I just released merch. Little Prego buddies there. So cute. So cute.
That's so cute. I'll have
So
to get
yeah,
some
anyway.
merch.
Yeah, it's very cute. I highly recommend the blanket. It's super soft. My kids love it. So
Thank you so much, Tina, for coming on the
Thanks for
Green Nurse
having me.
podcast.
Pleasure.
I'm sure I have to get out to a comedy show. I have to do
Yeah.
dancing TikTok, and we
Yes.
definitely have to meet. We got to meet.
Absolutely. In person.
We got to find the time, the space, and
It's
we're gonna
happening.
do it.
It's happening.
Thanks so much for coming on.
Thank you.
Looking for a great gift for a nurse or someone who needs to learn about nursing? Check out my national best-selling book, The Wisdom of Nurses: Stories of Grit from the Bedside. Thank you so much for listening to The Gritty Nurse with Amie Archibald-Varley. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit the subscribe button so you'll never miss out on any awesome episodes from The Gritty Nurse. Thank you so much, and stay tuned until next time. Stay gritty.